I'm the assistant nurse manager here at MD Anderson, and I want to talk to you about navigating CNS radiation oncology, a nurse's perspective, give you what is helpful for you when you're taking care of these patients, things that we are highlighting that are important, and things that also help you with everything that you do is going to be in collaboration with your provider. So you definitely will lean on them when it comes to a lot of information that you're learning to give to your patients and also for your own practice. Again, I'm going to give the disclosure. Of course, I have no financial disclosure to admit to or any conflict of interest when it comes to this presentation. And then also this is strictly for educational purposes. So the objectives that we want you to know about and take away from this presentation is just, we're going to go over the overview of CNS because that is very important. The review of the primary versus secondary CNS cancers, talk about the CNS oncological emergencies, and then really focusing on the importance of clinical management for your CNS patients, and then the role in telehealth and management for CNS patients. So when it comes to CNS, we, of course, are going to do the big topic of understanding the very basic fundamentals of nursing when it comes to learning CNS. And these things are very important to you. And so you really need to understand the structure of what your patients may have and where their disease site may be. So you're looking at the four parts of the brain, and this is the cerebrum, which is the outermost layer. Again, that's your two parts, your two halves. You hear about your lobes, your various lobes that you see on those pictures, and you really need to understand the function of the brain. Remember, this is dealing with emotion, reasoning, language, movement, sense of smell, hearing, as well as perception of pain is also a part of the brain. When it comes to the various elements of the brain, is going to deal with, like you talk about the basal ganglia, it's talking about play an important part of muscle movement. When we talk about the cerebellum of the brain, you're talking about coordination of movement, walking, swallowing, and then you have the brain stem, and that is at the base of the brain, and you're dealing with, of course, nerve fibers that are there, very small, important role when it comes to breathing as well as your heartbeat. As for the spine structure, which we continue on down, that is a bony figure that, of course, we have divided into four parts as well. We're dealing with the cervical area, which is the neck area. There is controlling your breathing, it's controlling your shoulders, your arms. You have the thoracic area, which is the middle part of the spine, and you're dealing with your upper body strength, your chest, your abdominal function. The lumbar area is your lower part of the brain, which is the lower part of the spine, which is dealing with the leg function, and then you have the sacrum, which is dealing with where it helps control the bowel, the bladder, and the sexual function, and the sensation into the tailbone areas. And the reason why I really wanted to focus on those areas and give a quick overview of this is because when we start to get into the details of how to manage the disease, you need to remember where that actual tumor is located. And that is the reason why I wanted to focus on there, give another highlight of what is going on, just kind of refresh your memory, because we don't deal with it. If you're not dealing with CNS every day, then those things you don't think about, but these are things that you can always refer back to when you have any patients have any concerns, or it may also explain some of the symptoms that the patient may be going to and why they're having the symptoms that they're experiencing with CNS radiation. So again, CNS, we're dealing with the brain and the spine. When you finding out the diagnosis of CNS diseases, typically they have a CT scan, or either they wind up having an MRI, which leads to the diagnosis of having brain cancer. So there are two components when it comes to CNS service. When it comes to the brain, you can have either primary brain tumors. That means that the brain is the primary location. It originated there. I'm not going to go over all of the type of brain tumors, but I'm going to highlight some of those. Of course, we hear the gliomas. When we're talking about gliomas, you're talking about those astrocytomas. These are one of the ones that are very more common that you hear about. Astrocytoma, you have low grades where you're talking about grade 1, grade 2 astrocytoma. Then you go into your anaplastic astrocytoma, which is grade 3. They're a little bit more aggressive in nature. And then you hear about the most most people hear about GBM, which is glioblastoma, which is a grade 4 astrocytoma. And this is the one that lately has been talked about in media because a lot of prominent individuals have recently passed that had what they call GBM or glioblastoma. Then you're dealing with your meningioma patients. That they are my most interesting patients because I think they have an interesting personality. To this day, I don't know if it's related to just the disease itself. They tend to need a little bit more additional care if you ever have managed any of these meningioma patients. And then we have our pituitary lesions. We also have ependophagot and ependymomas. And then we have our sarcomas. Most people are like, oh, that's a bone. You're talking about something soft tissue. What we're talking about here in the CNS portion is more of the chordomas. And then you have the gliosarcomas, which acts and functions similar to glioblastomas. And then we have our schwannomas, or you may hear about acoustic neuroma, which is something when it comes to hearing. And that is why knowing the location, knowing the disease is also important that you're dealing with when it comes to figuring out some of the symptoms that they may be experiencing, and then also some symptoms that you need to inquire about if you have a patient who has acoustic neuromas. They're usually going to have surgery, but we'll talk about that a little bit later. Surgery to find out the diagnosis because finding out what the disease is important to how the physician is going to treat it. So that depends on the grade, and that is very important when it comes to our treatment as well, when it comes to the dosage that has been delivered. Secondary brain tumors are our metastatic disease. They have cancer, either breast, lung, melanoma, and now it has come to the brain. And so now they're asking you to seek treatment. Usually these treatments they're looking for is stereotactic radiation treatment. Some patients wind up having some whole brain radiation, but that I'll go into as well a little bit later. When it comes to the cancers of the spine, your primary tumors, of course, you can have a glioma. In the spine, you don't see it that often, but you do need to be aware that can happen. I have seen a GBM of the spine, though do come rarely, but that is one of the primary tumors that can happen in the spine. And then again, that chordoma, and it can be anywhere in a part of the spine that chordoma can house and be able to be treated. Secondary tumors, again, secondary tumors of the spine, again, it's just meaning that the cancer started somewhere else, highly disease that is renal cell. They love to go to the spine. So that is something that you need to be aware of. They're going to come from any other site and they're going to grow or spread to the bones of the spine or spinal cord. So we'll go to the types of radiation treatment. So this is where when we're dealing with primary disease, we can treat it either with IMRT, you hear, which is intensity modulated radiation therapy, VMAT, which is volumetric modulated arc therapy, stereotactic radiation can occur. And that's really where you're going to see some of those benign tumors who are going to be treated with this. And then you also have your more specialized treatments that can happen, brachytherapy, proton therapy. This can happen with any of your patient populations. And then secondary meds, that's where you're gonna see the whole brain radiation. Whole brain radiation meaning we are treating the entire brain because there's disease, numerous amount of tumors in the brain. It happens with these METS patients. And so we can do them two ways. We can do what we just do standard whole brain radiation, meaning that we're not sparing anything. And then we have our whole brain with what we call hippocampus sparing whole brain. And that means that there is no disease in the hippocampus area of the brain. And that is important is because that is your memory center of the brain. And what we're trying to say is we're trying to spare that. Because again, whole brain is radiating the entire brain. So there's going to be a lot of side effects that's going to happen a little bit later on in life. If God forbid they survive that long, that they may see. So that's why that's important. IMRT, when it comes to IMRT, VMAT, and proton, the big takeaway from that can be delivered for your glioma patient, those medullo patients that has cancer. This is mainly seen in pediatrics. Most likely you'll have that in your pediatric education, which I think is up next behind. And then meningiomas can be treated with the IMRT, VMAT, or proton. pituitary, the sarcomas which is chordoma or gliosarcomas, can be treated with IMRT or VMAT. And then we go into that stereotactic radiation. So you're like, okay, primary and secondary treatment can both have it. Why don't you do this for everybody? This is meaning that they're given a bigger dose of radiation in a short amount of time, anywhere from 1 week to 1 day to 5 days. It's a very specialized skill set, and we do treat the spine with it. We can treat those brain mets up to certain limits, because again, you can't treat a whole lot of brain mets with this. Meningioma falls into that category. Your pituitaries can be treated also with this. And then your acoustic schwannomas, which is a primary disease, but it can be treated and typically are treated with what we call SRS, stereotactic radiation. And then we go into gamma tau, which is something that is our brachytherapy for CNS. It is this new way that you're going to do in surgery. So you, of course, have neurosurgery to be a part of this case. The patient is going to surgery. They are going to remove the tumor, and in there, they're going to put this, what we call, look like a little mesh of fiber inside the brain, and then they're going to close up. That's where your radiation oncologists come in. They need to know a lot of details before they do gamma tau, just because this need to be ordered. So what the diseases that are going to be treated here are some of the patients who are newly diagnosed malignant intracranial mets, and then also recurrent intracranial cancer, which is a recurrence after SRS. They have already had prior treatment. Also, the recurrence of meningiomas and GBM are also types of treatment recommendations that those patients may see.
We have a really interesting question on the chat. There's a lot of buzz. So there are so many techniques for CNS treatments, and you did mention hippocampal sparing. So what is hippocampal sparing, and why is it important, especially for our patients? Just a bit of an explanation for that.
Okay. Hippocampus sparing, whole brain radiation means, like I told you, is disease that they have cancer throughout the brain. But when you look at imaging, that's when the images come important for the physician, the radiology images of the brain, which is usually MRI. They're going to look and they're going to see where all these tumors are located. If this particular area of the hippocampus in the brain does not have disease, then you're going to do a hippocampus sparing radiation, whole brain radiation. And the whole purpose of that is because you're trying to spare memory. When you're beaming in the entire brain, you're not sparing anything. You're just beaming in, trying to really take care of all the tumors that are throughout the entire brain. But then with technology and advancement in radiation oncology, the hippocampus sparing is another way, so you can try to help the patient with those late side effects that may come with receiving whole brain radiation.
Absolutely. And also to add to that, the hippocampus is an important structure in the brain that's related to memory, learning, and also emotion. And it's a quality of life issue, as you don't want to lose your memory. So preserving that part of your brain is important to not only to us, but also to our patients who have brain disease. And some of these technology has come so far that we can contour out the hippocampus and put in those restrictions to make sure that we spare as much as we can. So thank you for that explanation, Dametria. Feel free to continue asking questions.
And Dr. Beckerman, feel free if there's something you want to add to that, you can.
Yeah, I think you guys are doing a great job. It's just a technique where we would basically treat the entire brain and then have dose limitations to the hippocampi, which are these very small structures on either side of the brainstem in the temporal lobe. And we know they house neuronal stem cells that actually repopulate the brain after injury. And that could include the injury from radiation therapy and can help people with their short-term memory in the future. The effect is not large, so it is a benefit, but a relatively small benefit. Many patients who would benefit from whole brain radiation therapy, I think, should get it. And if you're at a center that doesn't have the capacity to do hippocampal avoidance, which is an advanced technique, then I think many patients can still benefit. The effects of whole brain radiation on cognition, memory, things like that are typically actually fairly subtle. Many patients don't notice. It's all when we're doing whole brain radiation, it's always in the context of a much more aggressive threat from the disease. So we don't want our patients to fear that therapy if they would benefit from it.
So we're going to go into the next area. It's going to go to the clinical management when it comes to radiation, whether we the consults, the patient education, the side effects, and what happens after radiation. So your patients have received a diagnosis for whether it's a primary diagnosis. So if it's a primary disease, we know that our disease site is not the best disease site. It is a very glim disease site where the expectation of life is not very long. We prefer them to have that conversation before they see us. And once they see us, they can really absorb the information that we receive. Usually that's either going to be that information about their diagnosis is going to be either given by the neurosurgeon or it's going to be given by the neuro-oncologist. When it comes to your secondary patients, secondary meds patients, that means that they already had a medical oncologist and their medical oncologist have been doing scans, whether they were having symptoms or not. They have now had an MRI scan that revealed that they had now mets to the brain, meaning that their cancer is progressing. And so during your consultation, when you see, you're going to meet, of course, the entire team. So they receive this diagnosis or this intervention saying that we need to proceed with radiation oncology. When they come to see us, this is important things for us to know about is knowing, again, awareness of the treatment recommendation, because that's why you need to know this is a primary versus mets, because if you notice, the treatment modality is different depending on the disease site. So that's why that is going to be important. And then you're going to start doing your local focus assessment. And so you want to know about the onset of the history. And the reason why that comes into two folds, it allows you to do some of your assessment right then and there by having the patient speak in their own words of what happened and get their perspective and what led to them seeking medical attention. Did this happen 2 weeks ago? Was it an accident? Was this just a random find? Those are things you need to know. It also gives you the ability to see if there's any neurological deficit like speech, memory, and hearing issues when you're having them relay this information to you. So you checking some of those boxes off while you're doing this intake history from them, what led up to this. And then when it comes to dominant hand, that you think that's not important, but it really is, because that also talking about what they do for a living, the daily impact, the location of the tumor, what functionality they may not have. If they're right-handed, the disease is on the left side of the brain. Now it's affecting the right hand. What does that look like for their future? Do they need physical therapy? Where are we at on that aspect? And then it also, when it comes to the effects of the radiation that can possibly happen a little bit later, if you notice there's some changes. And then what they do for a living, again, that's a daily living functional impact. If this tumor is affecting their speech and then you learn that they are a professor, they may not be able to do that role at this moment. So again, that means that's time off. So that is important. So you know, and also for the provider to provide certain things that they may need to talk to them about. Their recommendation, we all have ADL, a recommendation that you can do, ADA recommendation that can be applied in your own profession based on whatever you may have going on. Symptom history is more of finding out if they have had seizures in the past. Was the seizure the reason that this all started? Did they have seizures? Have they never had seizure, but that they're on some seizure medication? That seizure medication could be prophylactically given because they had surgery. So you're looking at what is their management. If they had the history of having a seizure, was the seizure, what type of seizure did they have? What are their management? How are they doing? Do they have a secondary response for a breakthrough seizure if they need it? Do they have steroids? Are they currently on steroids? That's important to know the dosage, the frequency, and even the length of time that they've been on this medication. Some of our patients, I've noticed that they get on the steroids because they see that they have they have brain mets, tumors, and they put them on the steroids and they've been on it for months. We as nurses, we know the long-term effects of being on steroids for a very long time. And so those are things, that's why that information is important. Headaches. Again, that is very important to know about when they have them, where the location, if they had a history, because maybe they have a history of having migraines. And that's the reason why they ignored the symptoms that they were having because they have that history of having migraines. And so now you need to be aware that this patient now is probably going to talk to you a little bit more often when they have these history, these headache symptoms, because now they're trying to distinguish, is this related to the cancer itself, or is this my just my regular history of having a migraine situation? And then you need to know, of course, when spine patients, I think the biggest thing to know about them is, can they lay flat? Because when you're treating these patients, they do need to be supine. So you need to know, how do they lay? Are they able to lay flat to sleep? Are they sleeping upright? Because that also is important information to relay to your provider. Because say, hey, I may want to do this stereotactic radiation treatment, but if they can't lay flat, then what are the other alternatives that we can do? Can they put a wedge? Can they do a lot of things to be able to deliver the radiation treatment? And then also pain. Pain is essential, really more so in spine patients, but also in our other patients, because you need to know the history. What are their management, where their location is, what is it like? I always ask them, without medication, what is your pain score? With medication, what is your pain score? And that gives you a history of, do you need to add further management outside of your service line to assist? Do you, if you have the capability of putting a pain specialist or supportive care specialist on their team to help deal with some of these issues that they may have, because eventually the radiation is going to end, and who's going to manage this? And you really want your patients to be at best, have the best tools in place prior to you leaving. When it comes to, after you gather all the information from your team, there are other things that you need to know about. Have they had prior radiation? This is important because if they had prior radiation, it's going to affect the physician's treatment plan. So we also need to know how much they have received. We need to know where they receive, if this have already been prior treated. So their treatment plan or their decision making is going to be driven by this information that we need to acquire to give to the provider. You can, if you have a chance to get this information prior to the consult, that is great, because you picked it up, you looked through the chart in advance when you were reviewing, and you notice it, you're going to get that information. If not, you need to get that information right then and there. And so you can fax off and try to get those radiation images, and images as well as dosage in to you. When it comes to information about chemo, immunotherapy, targeted therapy, again, that's important to know, because sometimes radiation and chemotherapy, if you can't give it at the same time. Sometimes the chemo is a little bit more toxic that you cannot give radiation at the same time. So that means you may need to go in a window. You need to let the provider know, this is when they had it last, this is what they say, and this is their next treatment course. And they could have that communication with their medical oncologist. And so it can come. Then there are also the other options that can happen is, they want to continue their chemotherapy and they want us to come in a little bit later. And so that also helps with planning and expectation for the patients. And that also means that there's going to be a follow-up visit, so this patient can come back to see you later. And then y'all going to start to talk about, they'll start to have the conversation about when to deliver the radiation. Implanted devices is very important, because we don't want to knock out any important device that they may have, like a pacemaker, if they have a continuous glucose monitor. Those things are expensive, so you want to be able to manage that with their endocrinologist. Hey, they're going to do 6 weeks of treatment. We don't want to put that on and it won't provide them with the right reading. Neural stimulators, do those things need to be recalibrated after radiation treatment? Pain pumps, will we cause damage that will knock this device out? So that's the reason why it's very important you to know. And another key important information is pharmacy information. That is important because you never know when you may have to get medication to the patient. You need to already have that information on their files, so you can be able to, your provider can be able to write the prescription, call in the medication, or send it to an e-strip prescription just to send to the pharmacy, so it can be in there for them.
Yeah, before you go
Mhm.
on, just have a question. Our nursing team, I truly recommend and respect them because they're the first point of contact to the family and to the patient. And how do you navigate these discussions with the family? Everyone is coming in so anxious, especially for that first visit. And you're the first person, the first provider they see before the radiation oncologist. How do you handle that?
So the biggest takeaway when you first, that's the reason why it's really good that they already know their diagnosis. So they had a time to that initial, hopefully that initial shock of what they have has worn off where they will be able to receive that information. I always tell with my primary tumors, it's very easy to do because the mothership is always going to be their neuro onc. And so when you say that, it's that they are going to be the central person on your team. Always let them know. But when it comes to us here, we're here with you too, the entire team. We're going to see you. You can stop by anytime. The therapist is there every day because they're going to see them every day. And just let them know that this journey is not their own. This journey we're going to take with them. They usually help them out. Tell them to be open, to have conversation. It is time to really have those hard conversations with your loved one. It's something that you don't want to do, but that's something that we have to do. And if you need to talk to someone, it's okay. You can either see a therapist, that's perfectly okay. But it's also important for your family member to also know that they need to discuss too, because this is a life, some of them is a life changing event, especially when your caregiver is a home, she stays at home, when it's the spouse stays at home and they don't work. Well, what does that look like for their future? So there's a lot of decisions that these patients are going to have to make that you won't be able to address, but you should have the support system there to help them. Let them be able to say, you can talk to me, let me know how you feel, whether I need to get social worker involved so they can start talking and having those discussions. Do you have a support group there that these patients can talk to other people going through the similar situation that they're going through? They are also helpful. And so just building that relationship and being very open and receiving goes a long way, smiling and then just re-encouraging them that they're not alone when it comes to this radiation, their journey through radiation.
That's really wonderful. I feel like the nursing team is always at the forefront and we appreciate everything that they do.
Yes, thank you. So you're going to continue the patient now. The decision was made, say they're going to do the radiation treatment, you're going to go there. And now it's time to talk about that key educational information when it comes to going to simulation, what that looks like. They make it a mask or they're getting a frame price, depending on the radiation treatment that was selected. Again, treatment itself, it can go from anywhere from 2 to 6 weeks of standard radiation treatment. That's where you're talking about whole brains, the IMRTs, the protons. And again, those stereotactic radiation are usually at those higher doses of radiation giving, and that's going to be one to somewhere between 1 to 5 treatments, depending on the provider's recommendations. When it comes to treatment side effects, with primary to these, what I call fractionated radiation treatments, usually your expected symptoms really going to show up once they get enough dosage in. So most patients will start to complain about symptoms around treatment 13, treatment 18, which is around 3 to 4 weeks into the radiation treatment. And that's important to know because it's a building block. And so now they're starting, and it's okay every time you see them once a week, at least we do, we see them once a week doing treatment to allow them to look for some of these side effects to see what's going on, to tell them that yes, you're progressing fine. We're going to manage any of those side effects that you may have. And so you just need to always remind us, tell us, and be open about any symptoms. We can tell you it's nothing to worry about. We can tell you it is something to worry about. I know one treatment in particular I like to point out is the whole brain radiation. It usually been delivered in 2 weeks, so it's 10 fraction. And you just heard me say they usually not going to have any side effects until treatment 13, 18, 3 to 4 weeks. The treatment has already been delivered. Or are they going to have side effects? Yes. The biggest complaint with whole brain radiation is that they're going to lose their hair. They would do the entire, it's not uncommon that they do the entire treatment with no hair loss. And then week 3 or the next week after radiation's finished, they said, my hair is starting to fall out. You need to know that's normal because the radiation is still working in the body. And so you still will have radiation side effects up to 4 to 6 weeks post treatment has completed. And I hope that makes sense. And I hope when we get into some of the side effects, it may make a little bit more sense to you and how you manage it and letting them know again, because we turned the beam off doesn't mean the side effects is going to go away right away as well. When it comes to stereotactic radiation treatments, those treatments side effects are not going to be the same as those who are receiving treatments the entire for 6 weeks. It may look a little bit different just because of the dosage being higher and shorter. And I will point some of those out when we go into each of the side effects. Side effects when it comes to the brain. We tell patients that they may have headaches, which or we may call brain swelling. So your patients may report drowsiness, restlessness, confusion, headaches, or the vomiting. The radiation can cause the brain to swell a little bit. We know that. So again, those are things that you're expecting the patient to, some of these things you're expecting the patient to complain about. So these are, or they may be temporary symptoms. These may be symptoms that may already be present, but they're starting to increase in severity. You need to know that. That's why that is very important for you to understand when you're looking at the patient and they're making complaints about I'm having headaches. What does that look like? Are they having headaches? Does this headache start? When did it start? It's like before treatment, after treatment, those are important information because we know the brains can be irritated. And then they say, oh, I took a Tylenol and it went away. What is your implication for that? You can say, okay, maybe next time take your Tylenol before your treatment, especially if they say it happened after treatment and it went away. But also the information is could be steroids. They're having this headache, they're reporting headaches and they're on steroids or on a tapered dose. And now they notice since they tapered down, their headache has returned. That's important information. Their dosage, what was their prior dosage, because you need to relay that to the physician to let them know there is a clinical change going on as we taper down while we're doing a course of radiation treatment. And usually their advice back will be have the patient go back to the prior dose and stay on that dose for X amount of time. And as we give steroids, they are a protein pump. We get what we call proton pump inhibitors, and that's where we're talking about the protonics medication to help coat the stomach so we don't have any additional symptoms related to the steroids being given. But you always want to report these symptoms to the physician just to give them, some of them are just going to be FYI, but you definitely want to report it just to make sure that they are aware. And when we see them during that week, we can see if there's any improvement or if there's something additional that we need to do or take care of. The next side effect is fatigue. Fatigue is a big side effect when it comes to radiation in general for any type of treatment that you're doing. The reason the patients talk about they're being tired, they'll talk about being exhausted. Usually, the best recommendation is figuring out what is going on. What did they do? I've noticed some patients will talk about they feeling this way. They went and bring in a whole lot of things. Sometimes you have to tell them to pull back. Radiation acts it's burning energy, so you won't be able to do everything you used to do. We want you to continue, but you may need to pull back. And so that is very important information to tell them. You're not telling them say, oh, you just need to stop and just stay at home. No, you're just telling them that you may have to pull back some of the things that you used to do because your body cannot do that at this moment doing radiation treatment. So the fatigue, it can be last 3 to 4 weeks after treatment. Again, we encourage them to take naps. If they are a sleeper like me, I can go to sleep and still go to bed at any time. But some patients can't do that. So you tell them to limit it to 45 minutes or less and try to do that before 3 p.m. The other thing is most patients, and I don't know really what is I hear the most is they're tired between the hours of 1 p.m. and 3 p.m. It doesn't matter what time they receive in the radiation treatment. They're just complaining that they're tired. And so you want to really tell them, hey, at that time, try not to do anything. That's a big thing that you can talk about to them. Limit yourself in that time frame, and that can help with some of the fatigue to allow your body to rest. The skin changes, again, CNS, you don't see it a lot of skin changes. Sometimes more with the proton patients. They have more skin, but you will see some skin changes. You'll see some redness to the skin. You see the darkness of the skin. And that's because you will see that more so with those who are giving high volume radiation treatment. And they have a darkening of the skin versus that redness because remember, the dose is not building over time. They have their dose and it's received. And so therefore it's going to be there. But you always want to look for signs of infection. Some are a CNS patient had surgery, so you always want to look at that surgical site to make sure there's no issues because they may have developed an infection underneath there, and that's really the source of the problem versus radiation. Radiation just enhanced it, and then you want to send them to, of course, to neurosurgery so they can have a look at that. Also, protect the skin. Protection for your skin is always protecting the area that's being treated by keeping it covered. Whether you're using a wide brim hat, whether you're using a regular hat, just make sure that, or a scarf, just make sure it is protected at all times when you're in the sun. You do not need any additional radiation effects that will also cause dryness of the skin, because radiation is already doing that. And then again, you can always use your radiation toxicity tool, which is CTCAE, and you can look at what that looks like from grade 1, from 0 to grade 5, which is death, zero's no change in pain, and the redness, and decide how to manage and who's going to manage that skin reaction. Sometimes you may have to go outside of your area to go to a dermatologist to help manage some of those symptoms that you may, or wound care specialist to help manage the symptoms from the radiation on toxicity. But always continue to monitor your skin. That also remain one thing I would say is, when you're taking a shower, you may need to pull off that really hot shower. That's dryness. You can't dry your skin to that manner. So you're going to have to pull back some of the heat that also comes with washing the hair, making sure it's clean. Those are big things that you need to think about too.
Yeah, Demetria, all of us like scalding hot showers, but
Yeah.
probably not the best when you're having skin reactions. So just to monitor the chat, really great questions. So do the skin changes apply to the whole skin, or is it only in the area that the patients are getting treated?
It's only in the area that the patient's being treated. So where your radiation side effects is only going to be in the when it comes to skin, it's going to be only in the area that we're treating. Now, that's not saying that it's not going to be on the other side. Sometimes we have had where the dose come in, the dose need to have an exit site. So you may notice a little hair loss on the opposite side, and that's because the dose is out. The good thing, if they ever say anything about something on the opposite side of where we're doing radiation, look at it and also report it to the physician. The physician will always go in, or very good at going in and saying, "Hey, yes, this is here because of the dose exit out from this angle." Like I mentioned, proton is getting dosage right as it enter into the body. So you do see a little bit more skin issues when it comes to proton patients. And that's just because of the delivery of being proton treatment versus photon treatments, which is our IMRT type of treatments.
Wonderful. And we have another question. Someone is asking, why will a patient still get swollen head? I guess they mean increased intracranial pressure after receiving radiation therapy. So why does this happen?
What has happened? So I will go over that a little bit later too. So maybe I'll hold that question to a little bit later, and maybe I'll address that a little bit later, so it can actually explain what may be going on with the radiation. Okay. So how about hold
Absolutely.
that question and I'll get to that one.
Absolutely. We'll hold some questions to the end.
Okay. When it comes to, and I see Dr. Beckham is also helping with some answering some of those questions too in the chat as well. So another side effect, again, sore throat. This is because you're treating the spine. You think about where we at. Are you doing base of skull, the base of the brainstem area? So you're a little bit lower. So you're in that area where we are doing some treatment. So again, you may have some patients complaining of difficulty swallowing, irritation, or soreness. This is again a side effect when we're doing those radiation to that brainstem or upper spine. These are something that we are going to look for. We're going to either use lozenge or spray, numbness medication. A lot of people know of Zaloxolin to help swish, and they may also need swish and swallow. But a big takeaway for you is to eat soft food that is easy to chew and to swallow. Foods that are cooler or at room temperature. Avoid things that are spicy, salty, or rough or dry, because that's going to further irritate. Same thing you would do if you weren't having radiation treatment, you would do with everyone else. And then hair loss. So this is where we have the hair loss that may occur. Again, the skin may be irritated in that area. So you're going to notice, because we're treating that area, the hair loss is being affected to that area. And so that is where we're going to lose the hair. But like I told you, sometimes when that exit beam, it comes out, you may notice some hair loss to that area as well. That is something that can easily be explained by notifying the provider, letting them know. They can show them how that is working, why that is happening. So again, letting them know this is going to happen. Some patients say, "Can I just shave my entire head?" That's fine, as long as you do that before the simulation, because again, we're making a mold. That mold is going to be molded to what you look like at that time. So if they want to do that's perfectly fine. They just need to understand they need to do that sooner versus later if they trying to go completely bald. Patients who are with long hair, sometimes they don't want to do that. It's a woman thing. They love their hair. They cherish their hair. You can talk to them about, of course, hair. We can do wigs. You can get creative, make them feel good. I love to tell them now it's time to just try something different, give a good different look. I like to do that, and they seem to find that is very helpful. Oh, I could do a different look. Let me try a different hair color, see what I like. The hair will grow back, but you just need to give it time. 6 to 9 weeks before you notice, after treatment, before you notice that hair regrowth. It may come back a different color, different texture, a different texture, but just know that it will go back. You also want to reduce dyeing. Anything harsh after radiation treatment, during and immediately after radiation treatment, like hair coloring, you need to limit that to a little bit longer out. Probably wait till you start to notice some regrowth before you put something harsh on the body. Washing the hair is essential when it comes to radiation. That also helps the skin. So this was twofold. It's helping the hair and it's also helping your skin. You do need to cleanse that area. So it's important to wash it, but you cannot do this. You cannot wash your hair every day. So I usually tell the patients to wash it once a week. Do it on like a Friday after treatment so they can have the weekend. And you want to use milder shampoo, similar to if you had surgery. Use something that's milder, that is not harsh, not as really saturated alcohol that's going to cause more dryness to the skin. Avoid excessive brushing, combing, curling during this time. But also when you're washing, make sure it's a good moisturizing conditioner that you are using to try to put some more moisture back to the follicles to help stimulate that regrowth and also help stimulate the skin as well and give moisture to the skin. Loss of appetite and nausea, of course, that can be going on. That can be going on. I know my primary brains can be having the nausea because one, they're doing chemotherapy at the same time. So you really don't know if it's chemotherapy or radiation that's causing this issue. But you want them to know that, hey, we can manage it. And that's the big thing. It's about managing. You do not want them not to eat. If they're expressing they don't want to eat, they have this low energy, you really encourage going to small meals, those six to eight small meals throughout the day. You don't really care what they want to eat. Just eat something that is high in calorie and high in protein. Just again, remember protein can cause kidney stones. Make sure you pay attention to that. But definitely eat. If they want ice cream, let them eat it. This is not the time to do a diet. A lot of patients want to say, oh, well, this is a chance for me to lose weight. We really need energy. So food is a source of energy. So you want them to eat. If they're complaining of nausea, make sure they take their nausea medication. If you're treating the abdomen area, because we're treating the somewhere in the spine and the abdomen is in that way, they may want to take that nausea medication 30 minutes before they receive treatment or an hour before they receive treatment to maybe help some of those side effects that may occur during this treatment course. But again, if you start to have some nausea or vomiting, and you want to take that nausea medication around the clock. So that is important. Hydration is also important, even though when I have a loss of appetite and nausea, we don't want to have to deal with now dehydration. So again, 64 to 80 ounces are very good to take care of during this treatment. Pain flare is very important for our stereotactic radiation treatment, meaning that we're doing high dose radiation to the spine. This is one thing that you really, if you have the capability in your facility deliver this treatment, this is something that is very important. It's a temporary flare up of pain to the site that we treated because we have irritated those nerves because of those high volume of radiation that has been delivered at that time. They're usually going to report this symptom right away within 24 hours of treatment. Sometimes it go a little bit longer, but usually within that 24-hour period, they are going to call you, say, hey, I'm having some pain. So those are things that's why it's important for you to know this. You need to know what is going on, where it's at. You also need to know symptoms that can relate to that area, as well as if they're on steroids. And again, steroids is what we use because, again, we irritated the nerves. So that is the best treatment. They'll tell you that they've been trying to take their narcotics and it's not helping because it's not going to help. So you definitely need to ensure that they call you if they should have any pain after stereotactic radiation treatment. Diarrhea, rectal irritation. Again, this means that we're treating somewhere lower in the spine area. So they may have some changes in bowel function, whether it's frequency, pain, or soreness to the rectum. Again, look at this, to have them look at the site if you can't look at the site to see what's going on, if there's any more issues. But otherwise, you just tell them it's going to be more management, understanding again to fluids, because you don't want them to continue to be, they're having diarrhea. You don't want them to be dehydrated. You also want them to reduce the amount of fiber and fat in their diet during this time, because that'll avoid foods that are high, that will cause cramps or either gas. If they're having diarrhea, avoid eat foods that are high in potassium, such as bananas, potatoes. That would be helpful during this time. But just know that, hey, if they're taking medication that they're taking is important, because they're taking Miralax every day. Oh, you have a diarrhea. I need you to pull off the Miralax. I need you to pull off the stool softener at this time. So those are also important things to be aware of and take when you're talking to your patients and looking at what they're actually going on outside of just the radiation treatment, but medication wise as well. Oncological, oh, sorry, what to expect after radiation treatment.
We may be experiencing a bit of issues.
Okay, can
So
you hear
because
me now?
yes, we can.
Okay, okay. What to expect after radiation treatment? Just remember, they're going to see you 1 to 3 months following treatment. They're going to probably have some images that are also going to show you the treatment response that's going on with radiation treatment. So that last visit that you see with them, always explain that to them. We'll see you again. They're going to have the images. That's when we'll see the effects of what radiation has done. And so it do need to have some time to do that. Someone said, "Can I have it right away?" No, radiation needs to take effect. So those are things that you need to be aware of. This is where you're going to also talk to them about post side effects, post treatment effects. Again, because we stop, today is the last day of treatment or tomorrow's the last day of treatment, these side effects can still linger. They can linger up to 4 to 6 weeks post treatment. Usually it peaks around 3 weeks around finished treatment, where they feel really tired. Tell them that's normal, that just continue to do what they need to do, try to move around, go outside, don't just lay around, because we don't want blood clots, we don't want pneumonia, we don't want any of those type of things. But each week is going to get a little bit better, so that next week you'll feel a little bit better. By now we at week 5 from treatment, you feeling a whole lot better. Now this can change, because they may now be starting a chemotherapy. So now you have a chemotherapy that's going on, and it's going to make them feel a little bit more awful at that same time while you're trying to rebound from the radiation treatment. But just know, radiation treatment should not be lasting for forever. If there's something going on, you really need to just keep telling your provider, say, hey, this is what's going on. They can tell you, like, yes, this may not be us at this moment. The medical oncologist treatment may be systemic treatment, may be causing some of this effects, but we could always try it. And then if they have a prescription for steroids, you always want to make sure they at least have a tapered dose. Your provider know they're on the steroids, so they can provide this tapered dose, so they won't be still on it for extended amount of time, just because those long effects. And then again, continue to monitor the skin for at least a month after radiation treatment, just to make sure that there's no additional issues that are going on. So you're still going to wear those hats, still protect those skins. If you have people who loves to swim, again, put something over their head when they get into the water, just so they won't cause any further irritation to the skin. And oncological emergencies that we have, I don't want to think that they really wanted me to focus on is heart compression. And so this is what we're talking about with these emergencies. These are something that needs a medical emergency, and they need immediate treatment. So heart compression is one of the ones that can, if it's delayed or not caught, can lead to neurological deficit and paralysis if not addressed immediately. In the brain, this is where I was telling you a little bit earlier when we talk about that increased intracranial pressure. Again, that could be headaches, visual changes, projectile vomiting, or change in mental status. Again, these are things that you're not going to physically see. These are things that are going to be either caught on images, and but you will have these symptoms that these patients may be experiencing, and these are the reason why you need to send them to seek urgent care. Seizure, again, if they've never had a history of having seizure, and now they're all of a sudden having seizure, those are things that you need to take in place, because that means something's going on. You have brain herniation. Again, you can't see it, but your patients may be complaining of severe headaches. Your patient may not have really any symptoms. You're sitting in front of them and they in the room with you, and you look at them, and you don't have to have a pen light to see that one of their pupils are dilated on one side and the other one is not. You can say, hey, you can always talk to them and say, hey, if you're having any visual issues, have you had any surgeries to your eyes? If they say no, XYZ, that's something that you need to get your provider in to go ahead and come and see, to let them know that you see a dilated pupil, because you need to get them to the emergency room, because they're not showing the effects physically, but you are seeing it basically based on examination, and you recognize it. This should not be looked at. You should not be seeing a really enlarged eye pupil and the other one is not. And that is something you need to look at. Change in mental status, again, for part of herniation. Bleeding may be going on in the brain. Again, you can't physically see this. These images are going to be important for you for this, but they may complain of headaches, nausea, vomiting, weakness, and or numbness to one side of the body compared to the other side. Again, there's something going on. You need to get them to the emergency room, because they need to have some images, whether it's a CT or MRI, so they can know, hey, we need to do something right away. So when it's a little bit more about the spine cord compression, again, it can occur anywhere in the body and in the spinal area. The size, the location, and what it's affecting is going to be really what the symptoms are. And it's also going to be the level of issues that you have. Common symptoms, the first symptom is back pain that can be dull or aching. You won't know that there's a compression going on. There may be images that need to be happen. There's something going on in the body going on there, but the severity of it, you don't know unless you have images. But the patient is having this complaint of this back pain, dull ache. It may spread to the arms or the leg. They may complain, happen to have the numbness in the arms or the legs. Sometimes it feels like a belt sensation. They may have mobility issues, meaning that they cannot move their arms or leg. They have the loss of balance. They can't walk. They are now complaining of loss of sensation. There's the numbness and the tingling that's going on, but they also may have the bowel issue. And I can tell you, this is more of a late sign. If they have a loss of control of the bowel or the bladder, that is 100% need to go to the emergency room. You need to call 911. There is an issue. There is something going on, and you need to be able to say, hey, these are things you need to go to the emergency room for. You need to be evaluated by a higher level of care. And so those images are very important to have. So your consideration, again, recognize the symptoms earlier, because that is the leads to better outcomes, better management. Because what's going to happen is they're going to get them in. We're going to deliver that radiation treatment. They'll go to the emergency room. We notify the provider, and then they're going to get immediate radiation, because we're trying to take those, prevent any further damage to the spinal cord, and we're trying to improve the nerve functions. And so that's why this is very important. These are very high consideration that you need to be aware of, that can happen with a tumor in the spine. And so if you ever having a patient who has a tumor somewhere in the spine, you need to definitely tell them some symptoms that they need to, don't wait, don't delay, go to the emergency room, because this could be what's happening just because they have a tumor, and that tumor could have grown a little bit more and it's causing some compression, which is causing these symptoms. And these, especially if these are symptoms they were never having before, they need to go in. So now I'm going to be a little bit more interactive with you when it comes to the world nursing role, when it comes to healthcare and management. And the reason why I wanted to really focus on this area is because, like I told you, the advancement in technology has put us in a different format. We're not always seeing everyone in person. We are seeing individuals who are in a technology world, whether we're doing virtual visits with them, or they're sending us messages through my chart messages. Our system is Epic. They're sending us those my chart messages, where you need to be able to interact and manage these patients using the devices and the tools that you have in front of you. And then also it's going to lean on your role and your understanding of it, of what you need to do when you're talking to them in these other formats. So there's just a crazy question that one of my friends wanted me to really put out there for y'all. When was the very first documented telehealth visit? And the answer is, this happened in 1876. Alexander Bell splattered battery acid on himself, and he used the telephone to ask for help. So that is really where this telehealth originally started. And we wanted to make sure you're aware of that, that it's not something that we just developed because of COVID. We didn't just develop it because, this is something we need to do. This is something that was being done, but you wasn't really seen as a telehealth type of visit. When it comes to telehealth visits and management, if a patient call you, you want to gather the information, the reason for the call, determine if the symptoms is urgent, non-urgent. Also find out if they evaluate the patient's understanding of what your recommendation is, document your note, follow up on your call, and then close out the call and notify the physician. And I'll go a little bit more details, and I'll give you examples of why these key things are important. When it comes to that nursing judgment, that is really what telehealth is all about. It's all about you recognizing urgent emergent treatment, calling the patient, going to their local emergency room, having them go or either call 911, whichever system you have, versus non-emergent visits where you can call or message the patient. Then you advise them the patient of the symptoms, you schedule appointments or follow-ups, and you do referrals if it's needed. So let's go into some examples that I have put in place. So this is one on Monday. So you receive a patient message and it says, on Monday, my first dose of radiation. I had a very intense headache. Is this normal? Has resolved now, but I wanted to mention it. So what we know about this patient, there you have a GBM. We're doing IMRT treatment. This is a 6 week course of treatment, and a 33-year-old male. Here you will see that you want to look in the chart because of the information that was told. You want to look at labs. Always look at labs to see if anything's going on. He's complaining of a headache. We know that radiation can cause swelling. Let's see, are they taking steroids? Have they taken some steroids? Are they recently got off the steroids? Was this a symptom that they were complaining about before? This could have been a symptom that led them to knowing this is what's going on. And then also know that this is a side effect of radiation. So those are things that you're going to be thinking about. Having a mild headache after treatment can occur. Usually don't occur that fast, but hey, let me go ahead and call them just because they are having symptoms, because they were not complaining of it before. Let me find out if they took anything for it, because that is very helpful information. And did it resolve itself? So those are things that you're going to look for. And the reason why you're going to call this patient is because this is something new that they are telling you about. You really want to close the loop on that conversation, and then you're going to give this message to the provider to let them know. And what you're going to tell the provider, if they were on steroids, when were they on it? Did they recently taper off? If they're currently on a certain dose, again, what is that dose? And then you also want to know, say, hey, this only happened after radiation treatment. This is the first treatment, and just give them that closed loop. They may say, yes, your recommendation to take the medication prior is important, but let's see, and then we'll follow up with them to see if it gets any better, because this may be too soon to be having an effect from the radiation. Our next question is, my pain has increased since leaving yesterday. Please transfer me magic mouthwash from the pharmacy and send the script for the steroids to my Walgreens. It hurts bad enough that I am having difficulty sleeping. So what we know about this patient is your patient is a 55-year-old female who has thyroid cancer that mets to the spine. They just received stereotactic radiation to C3 to C5, and they had 3 fraction. It was completed yesterday. So again, what are we doing right now? It's going to do a poll question for you real quick, and it's going to say, for this patient with stereotactic radiotherapy to the spine, is acutely worsening pain after radiation treatment a side effect? So pick your answer and just let me know when the poll is finished. Put it up for probably about a minute so they can answer it, and then we'll close the poll.
All right, absolutely.
That's good. I think CNS is a very interesting disease site just because it's so large and you're dealing with two different aspects. That's good that they're interested and they're intrigued with it. It's a very unique service line.
Yes, absolutely. CNS is one of those that our patients do have this devastating disease that requires a lot of supportive management. And I think it's a really important topic for discussion. So we are about 57%. I think I'll
Okay.
wait till we are about 60%, 65% answered, and
Okay.
then we can share the results. Getting close
All right.
there. And again, feel free to put those questions for the Q&A segment in the chat. All right, we are getting close. I think we can go ahead and end the poll.
Yep. All
Okay.
right. End the vote. Yep. Go ahead and end it. Of course, the majority of it looked like they said yes.
So 74% say yes, and 26% say no.
Yes. So the answer is yes. And the reason the answer is yes is because, again, if I'll go back to the question, the patient has increased pain. One of the things that we talked about stereotactic radiation is that these patients may have pain flare. And so that is why what this patient is experiencing is what we call a pain flare is happening right away. And so we want to address that issue. So the answer would be yes. And so now, since we know that they had stereotactic radiation treatment, oh, sorry, we know that they had stereotactic radiation treatment. We need to know if they have the steroids on file. This is something we just started here where we go ahead and schedule them to pick up this dose of steroids. You want to call them and you want to tell them to take this medication. And the reason why you want to tell them to take the medication because you want them to say, hey, you're having a flare, take your medication, and then go from there. One thing that I can tell you that just recently happened with us, we had a patient who just did the exact same thing, had some issues. They were calling because they decided to take a Tylenol. And so the answer is no, go pick up that prescription. Go pick up the prescription. That is what it's for. But I also noticed that at the time they were doing 4 milligrams BID. It's 4 o'clock in the afternoon. So I told the patient, of course, to take that medication. And so to take the medication, go pick it up, take it as prescribed, but I also notified the provider to let them know, hey, the patient is going to go pick this medication up. I told them that you will probably may call and tell them take a different dosage because again, it's 4 o'clock in the afternoon. They won't have a time to get a BID dose in, especially with them having or complaining of a pain of 9 out of 10. And you want them to go in. So that's me recognizing, hey, not only that they need to take the medication, but it's also me recognizing the time of the day and giving that information to the provider so they can make that adjustment if they need to, based on the information that the patient is expressing. This severe pain, 9 out of 10. So you always want to follow up with your provider, call the patient. You can also send them, if they sent it by my chart message, you can message it there too, but definitely get in touch with them so you can talk to them about what's going on and follow up with your provider too. Sometimes that's a phone call, sometimes that's a message, but again, that's something that you really need to do so you can close the loop and really get that patient help. Another question that I have, a patient message is, I have a question for you. I have a 3-month follow-up visit and the MRI scan next month. I would like to find out if I need to keep this appointment or I can move the appointment back by 2 months to coincide with a 3-month follow-up with my med onc. Please advise. Thank you. And I look forward from hearing from you. So this patient is a lung patient, 47-year-old female. We never treated her. She's on systemic treatment. So what we know right now is that this patient is being followed by us, basically doing surveillance. And so now she wants to delay her treatment. So your responses, you look in, always look at your prior note to see what was going on so you can find out, okay, what was the recommendation? Your recommendation was to be in 3 months. You're also going to look to see, you can see some notes from the providers. Hey, they changed your systemic therapy, which probably explained why you didn't do any treatment. Your radiation oncologist didn't do any treatment because they're trying to see what the systemic medication could do. And then you also want to know the date of the last image. So of course, you're going to message the patient and you're going to tell the patient, and this is something that you didn't have to call the patient to tell. This is something that you can message the patient and let them know to say what the recommendation is to follow up in 3 months or come in sooner if you start to have symptoms. You will inquire with the provider if it's okay to delay that scan by those 2 additional months. And then your message to their providers, hey, your patient is asking if it's okay to delay the images for almost 5 months. So we're looking at almost 5 months out now for the rate to do some images and let them know that, hey, the last images was this day with your intentions to see them in 3 months. And the reason why you're doing that because you're giving the provider eyesight. They don't always have to go into the chart. You're telling them exactly the things that they need. So you need to make sure that your messaging, the providers are meaningful and impactful. You're giving them a picture of what is going on with the patient. You're telling them when their last images, what are they doing now? When they are proposing, if they are okay with that extended delay. Of course, the provider said no because there was some subtle changes, so she wind up leaving the schedule as scheduled, and we did not delay it just because of that. And that is why those key informations are important, and that was her message back, and that the provider wound up messaging back to the patient to also tell them that information. And then I think this may be my last questions that I have for you, but then we'll go to the questions and answer. It says, I just finished my course of dexamethasone on Monday. Unfortunately, I am still experiencing some pain, including weakness and a lack of concentration. Additionally, I'm having tingling sensation in my head as well as in both of my legs, arms, feet. I wanted to know if these symptoms are normal post treatment and whether they are likely to resolve on their own. Patient who has breast cancer who mets to the brain. We treated them with SRS and we treated to the cerebellum. So remember, the cerebellum controls movement. And so that's important for you to know when you're looking at this. And then also the important thing that you really need to know is she just told you that she had just finished her course of steroids based on her symptoms. So again, you still want to follow up with the labs. You still want to do those chart review type of things, but this is a patient that you want to call. And you reason why you want to call the patient is because A, they just finished with their treatment. And so you really want to find out what dose, their last dose of what they had going on. You want to see if there's some additional changes because she is reporting one of the things that she's reported is now she's having the lower legs, the arms, and the hands. This is probably something that wasn't there before. This may be something that may be happening now, and you want a little bit more details of what do they mean? Because tingling sensation, is it all over? Is it one side? Is it both sides? And you want to try to get that information. And that's the reason why this is better to be a phone call. Depending on what the patient says, that is what you're going to message to your provider to let them know. Oh, I actually had one more question. So this is the actual last question. So this is another stereotactic questions for you. This weekend I've had trouble eating anything that's solid. When I swallow, it feels like something getting stuck, and it really burns. So the patient's able to eat the cottage cheese and the fruit this morning, but last night had a really bad episode. I noticed this the last few days. Isn't there a cocktail? Sound like she knows that there's something that we can give her. So she's asking for milk of magnesium, lidocaine, and something else. So please get back to me ASAP. So this patient is a renal cell patient who admits we treated T79 and the patient is complaining of difficulty swallowing. So when you think about where we're treating and where she's complaining about, you don't really coincide with each other. So your ribs are going to be your T78 are going to be a little bit lower on the lower part of your ribs and your abdomen. So she's complaining of difficulty swallowing. That might not be related to. So the thing for you is this is not the difficulty swallowing is not related to her treatment that she have, but we know that this could be based on the information given and where we're treating. She could be having reflux because we treated some of that abdomen, that T78, so that may be causing some irritation, which made difficulty after she said something about eating. So it's okay to message a patient to tell them, hey, sorry to hear about the difficulty swallowing. This is not a typical side effects for our radiation treatment. Definitely always have them to talk to their medical oncologist because you're looking in the chart, you notice that she's starting some new chemotherapy. So this could be that side effect because unfortunately you're not going to know all of those side effects. And so that's important for information to tell the patient, but then you also inform the patient, of the provider, of what is actually going on, what she's complaining about, what's going on, and see if they want to advise something different for this patient. And so that's why this is another type of phone call that you want to make because you want to get additional information so you can provide it to the provider, whether you're talking to the provider by phone or whether you're talking to them by a my chart message. And so now that concludes my presentation.
Thank you so much. This has been a wonderful educational session. Thank you so much, Demetria.